My name's Jonathan Davis. I'm the Medical Director of NETS WA. I'm from Belfast in Northern Ireland, and I speak quickly. I'll slow down and I'll do my best so you can understand what I'm saying. So I've decided to pick thorny is probably the wrong word to describe it, but certainly with some noticeable provocation. Doesn't matter where preterm babies are born in Western Australia. Before I start into my talk, I just want to say that I and the University of Western Australia acknowledges that where we are is situated on Whadjuk Noongar land, and that the Whadjuk Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs and knowledge. So I am the Medical Director of the Newborn Emergency Transport Service, and I always assume, as we do in our team, that everybody knows all about NETS. I had a very enlightening conversation while you all were having your lunch, and I was feeling a little bit too nervous to eat, to the effect that the person I spoke to had no idea what NETS was. So I'm glad I put in the next few slides just to describe a little bit about what NETS is and what we do. We go to where babies are, we pick them up and we bring them to where they need to get the care that they need. That's it pretty much in a nutshell. We operate in Western Australia, which is the largest neonatal or largest retrieval transport area in the world. It's 2.6 million square kilometres, and if there's anybody here not from Western Australia, that's the size of Western Europe. It's like getting a phone call in the middle of the night when you're in London and saying, can you come to Warsaw and pick up our baby, please? We are the only neonatal or paediatric transport team in the whole of the state, where in Europe there are probably about 100 between those two places that I've just mentioned. What's on the screen to the person I was talking to earlier on, this is a neonatal transport cot. This is an intensive care unit on wheels. So we like to talk about people who work in static NICUs, like Trish. That's NICUs that don't move anywhere. Well, that's not exciting. But we have got mobile neonatal intensive care units, so we can travel anywhere and do what we do in the back of an ambulance, usually with some ginger to help the you-know-whats. So this is the workhorse, and behind is an RFDS aircraft, and we partner with RFDS to go to the furthest corners of our state. The longest transport distance that we do is 2,500 kilometres. That's here to Connemara, and that can take up to 12, 16, 18 hours, and that's a nurse and a doctor, usually a flight nurse, to provide neonatal intensive care on the move to whatever baby presents. I'm going to give you just a little bit of numbers in terms of the scale of what we do. So the numbers of retrievals that we've been doing over the last 15 years have been increasing. In 2021, we did 1,300 retrievals. That's about 3 a day, and that's 3% of the number of babies that are born in WA every year. We think that's quite a lot, and certainly when you're on call at night, it feels quite a lot. I'll have to skip back that slide because Kirsten told me I couldn't change my slides and I wasn't allowed to change those around, so I do apologise. So in terms of the national picture, we do benchmark what we do with other transport teams around the country, and we look at our activity and how many babies that we move. And this is a slide from 2022 which looks at the number of babies that are moved less than 28 days in each of the states and territories. The dark blue column, thank you. The dark blue column is WA, and we move approximately the same number of babies, about 750 babies, less than 28 days, same number as they do in New South Wales. Now, I'm from Belfast, where there are not as many people there are in New South Wales, and WA has even fewer. So the number of babies that are born compared to the number of transports that we do, we are head and shoulders above the rest of the country in terms of our activity, simply because we are a big state that is highly centralised in a little corner of WA, which means that we have got lots of work to do to make sure the babies get the right care in the right place. As Trish alluded to, I moved here from Bristol in 2016. But Trish didn't mention that we competed for the same job and she beat me, but we still see eye to eye. That's fine. forgive her. It was around that time that I was very aware that in WA we were known as being aggressively centralising babies so that they delivered in the right place. It's worldwide known that that was the case. But when I arrived, and the two are coincidental, may I add, when I arrived it became apparent that this was changing. Something was changing within our state, that the number of preterm babies that were delivering outside of tertiary centres was increasing. And this is a slide which in some ways demonstrates that. In 2004, the number of babies that, as a total percentage of the number of babies in that particular cohort, less than 32 weeks, that we're delivering was about 5%. By 2018, it had nearly tripled to 14%, and now it's hovering somewhere around the 10% mark. So that's double the number of babies in 2004 that were less than 32 weeks that are delivering outside of a tertiary institution and then need to be transported in that very fancy piece of equipment to a tertiary hospital, to a NICU for ongoing and definitive care. That's a big change. So we wanted to start to look at, well, is that bad? And that's where I'm going to sort of take you in terms of the discussion in the next few slides. And in 2023, we published a large cohort. And the good thing about WA is that because lots of places send our babies to one single place, we've got really good data. We looked at the outcomes to 5 years of outborn versus inborn babies born less than 32 weeks, and that over about a 13-year period. Now, we included babies from 22 and 0 to 31 and 6, and the reason we chose 22 weeks, I'm bearing in mind I'm speaking to a room full of people who look after people during their perinatal journey, is that some babies that were born in the 22-week survived, went to NICU and were discharged. So we wanted to make sure we captured everybody in that cohort. And we looked at everybody that was born between 1st of January 2005 and the 31st of December 2018. We excluded babies that were born and transferred into the state, or babies that were born and looked after in another institution and then transferred to the tertiary institution or from another hospital, for instance, Fiona Stanley, that started delivering babies in about 2015. And we also excluded babies with lethal congenital abnormalities. Now, I always assume that people know what I'm talking about when I start to say outborn babies, but an outborn baby in this case was a baby not born in King Edward's Memorial Hospital. Well, that wasn't a joke, but that's good. I'll ask later why that was funny, and I hope I haven't offended anybody. I'm just a jovial Irishman, so I can't offend anybody. And we also looked at antenatal steroids, and we defined a course of antenatal steroids greater than one dose, greater than 24 hours before birth. We were looking at death, short-term outcomes and long-term outcomes, and for the fact that I have a limited amount of time, I'm just going to focus on mortality and the short-term outcomes. I can let you know that the long-term outcomes over cocktails afterwards. We looked at death at 3 time points. So we looked at death before transfer to an intensive care unit within a tertiary centre, so delivery suite or theatre, before transfer to the tertiary neonatal unit, and then we looked at prior to discharge from the tertiary neonatal unit. So we wanted to look at whether babies made it from delivery suite, wherever they were, to NICU, and that includes within King Edward's Hospital. We wanted to look at brain injury, specifically severe interventricular hemorrhage, grade 3 and grade 4, so those are the worst on the scale of 1 to 4. And we wanted to look at cystic periventricular leukomalacia, so the ischemic type injury that the very important motor fibres around the ventricles will get. And then we looked at those two combined, and we call that combined brain injury. Now, the analysis, we looked at some univariate comparisons between inborn and outborn babies. We looked at the outborn birth rates because we wanted to, first of all, establish that we were seeing what we were seeing. We were pretty sure we weren't just making it up. We wanted to prove it first. We wanted to adjust for some confounding factors like multiple births, gestation, birth weight. We didn't adjust for antenatal steroids because it very much predicts whether you're inborn or outborn. So you, as I was about to say all the results, can't do that now, Jonathan. And we got all the data from the electronic database within King Edward's and the midwifery notification system. So we felt we had a pretty complete data set from when the baby was born anywhere in WA to potentially when it was discharged. So this is from the paper, and the important bit are the final numbers that we used to do the analysis. So we had about 5,000 babies that were born less than 32 weeks during that time period. 4,200 were inborn, and about 450 were outborn. After adjusting for those various things that I mentioned in terms of where babies came from and lethal abnormalities, we got down to just over 4,100 and about 387. We looked at the changes in outborn birth during that time period, and our very clever statisticians picked two epochs between 2004, 2014 and 2015 and 2019. And the number of babies that were being born outside of tertiary institutions has increased. It has increased by about 4 or 5% looking at the averages over that. We thought it was going to be very important to look at the maternal and perinatal characteristics, and we wanted to see what mothers were presenting and how they were presenting, and which babies were inborn and were outborn. And looking at the data, slicing it this way, outborn mothers tended to be a little bit younger. They had babies that were a little bit bigger. They were very, very unlikely to get a dose of, well, the majority of them were unlikely to get a dose of antenatal steroids. And most of them were spontaneously delivering compared to those who were inborn, which was the antithesis of that. So I'm going to move on to the mortality numbers, and I find these numbers, and I presented this data on a few occasions now, I still find them striking, and I still find them challenging, and I hope that it will create some good panel discussion about what we can do about this. But outborn babies, if you're not born in a tertiary institution and you're less than 32 weeks, you are 7 times more likely to die prior to being transferred to the NICU than if you were inborn. So that's coming from a delivery suite in Whoop Whoop compared to being in a theatre or delivery suite in the tertiary institution. You're 7 times more likely. Outborn babies were still over 3 times more likely to die before discharge. So even if you get admitted to the neonatal unit, even if you survive that transport process, you're still 3 times more likely to not make it home with your family than if you were born in a tertiary institution. Now, the very clever people amongst you, and I have to say I won't count myself in that number because the statistician told me this next bit, would say, but you included 22-weekers. Surely there is a proportion of babies in your population that were never going to survive. You're just talking about those. You're trying to scare us. So we excluded them. We took them out. You can see that the population spread, and quite a lot of those babies are born at 22 weeks and 23 weeks. So we removed them from the analysis to see if it got better. And it didn't. Excluding 22 weeks, babies were 12 times more likely to die before transfer versus leaving their place of delivery. Now that's shocking to me. That still keeps me awake at night when I'm having a conversation with somebody on the phone about whether to deliver a preterm baby, to risk putting the mummy on the plane, or to deliver it outside of a tertiary institution. We wanted to look at the brain injuries, and when babies are transferred, outborn babies have a 2.5 times more likely to, oh, that's the slide, sorry, duplicated, sorry Kirsten, I thought I got it right. Severe brain injury, nearly twice babies that were transferred who were outborn would have increased risk of grade 3 and grade 4 hemorrhages and combined brain injury. So even if you survive, even if you get transferred, you still are twice as likely to have a severe brain injury as a baby who was inborn. Now, this isn't my research work, but I thought it was a nice photograph to perhaps explain that the whole situation is quite complex. We've got mothers presenting often when they're not supposed to, perhaps more spontaneously if you believe that data, and less controlled, with less active obstetric management. And is the problem the transport, or is it that we have got a population of mothers who are sick, or perhaps are presenting in places where it is difficult to get from in remote WA? Or are these babies delivering in places with good obstetric management, but actually they don't have good pediatric management, so they're not necessarily getting the right type of resuscitation or stabilisation? Perhaps those methods are not quite up to date. Or are they being jiggled around in the back of an ambulance or a fixed-wing aircraft or a helicopter? So this is brand new, fresh, never presented before data of a 10-year analysis that we have done of all babies that have been transported less than 28 weeks. And we have compared those babies with those who have got an IVH, so an interventricular hemorrhage, so that brain injury, and those who haven't, who didn't get an IVH when they've arrived to the tertiary institution. So these are, again, some not related necessarily to the work, just give me an opportunity to put a nice picture up and to tell you that the IVH incidence in our total population is about 20%. That's not great. It's certainly more than I would have expected, and in that transported population is probably higher than the static NICU population. I found the conversation about antenatal steroids and the lung effects and the not lung effects, because as neonatologists we're fairly focused on the lungs, and we like to think that we give antenatal steroids to protect the lungs. And it was a two-edged sword. I'm either happy or sad that it was mentioned in the context it was mentioned, because when we looked at maternal antenatal steroids to prevent IVH, babies, preterm babies, less than 28 weeks, probably the group of babies that are going to have the most benefit outside of the lungs. The babies that were transported who did get an IVH had less antenatal steroid administration than those who didn't, who IVH didn't get it. Just try that again. If you didn't get steroids, you were likely to get an IVH. There we go, got it right. Used your trick. So that's something that we can do. Now, I was happy to see that, because that's something that we can start to consider, whether because some mothers present and you just can't get them out. And knowing that we can give antenatal steroids and that might be protective in this population of babies was at least something gratifying. We also looked at perinatal characteristics in these babies. I haven't put all the data here because it's still in a reasonably sort of messy format, but babies who had a higher first lactate and babies whose APGARs were lower tended to have more IVH than babies who had lower lactates and better APGARs. Now, does that indicate that the babies were sicker? Does that indicate that the mothers were sicker and they were really sicker babies? The cord lactates were also higher in babies who had IVH versus those babies who didn't have IVH. So I think we're starting to look at a perinatal story about the presentation of these mothers and then their onward transfer and what we might need to do to try and fix this problem. Now, I mentioned delivery room things that happened, and these being less than 28 weeks and this being Western Australia, one assumed that most of them were being intubated, but being intubated versus not being intubated was highly statistically significant for getting an IVH than those babies that were not intubated. Now, again, the clever people in the room will say, well, the smallest babies are more likely to get IVHs, and those are the ones you're going to get intubated. But I'm not sure I've been able to tease that out yet. I just know that if you're intubated and you're delivered, you're less than 28 weeks, you do have a high risk of getting an intraventricular hemorrhage. And surfactant goes along with that, but surfactant goes along with intubation. So again, I think we're building a story, we're building a picture of what perinatal circumstances might lead to babies ending up being very sick around the time of birth and maybe developing intraventricular hemorrhage. So we wanted to look at some transport characteristics, and yes, that is my bike, and it is parked in an ambulance space, but it could easily be moved. So we also looked and wanted to look at the transport characteristics, and whether you were born rurally or whether you were born metro, that had an impact on your rate of intraventricular hemorrhage, and the distance from the tertiary neonatal unit. And our initial analysis would suggest that neither of those two things makes any difference. So if you're born rural, if you're born metro, or you are 300 kilometres away from the tertiary neonatal unit, or you're 100 kilometres away, and that's still within the city of Perth, there is no difference between your rate of IVH. The next point is related to our ability to look after these babies within the transport environment, and temperature is very important. We looked at the temperature on arrival at the NETS team, so the temperature of that the baby had got to in terms of its zenith, its lowest point, and although just on the wrong side of that 0.05 value, worth mentioning that the median of babies who were likely to get an IVH was about 0.8 of a degree lower, and I used 0.8 because we know that within each increase, with each decrease in temperature by 0.8, you increase your mortality. So that's important. So temperature control is very important, and we've recently started a new course with the help of WACS, I think Kate and Shan are somewhere back there, hello, called NeoStars, which is given the size of our state, and if you call for a NETS team, sometimes it can take us about 10, 12 hours to get there. And what do you do in the meantime? We don't let you just, good luck, take care, call us, we'll call you when we get there. We're offering practical stabilisation advice prior to the arrival of a neonatal transport team, so that you can do the things that you would expect and the baby needs in order to optimise outcome. And we're focusing on preterm delivery. We're focusing on preterm babies and babies with hypoxic ischemic encephalopathy, because we know those babies are the most difficult ones to manage in terms of temperature control, in terms of size, in terms of other pieces of equipment. So getting the baby's temperature right is really important. Not letting babies get cold probably has a good impact on whether they develop a brain injury or not, if you're not born in the right place. So does it matter where preterm babies are born in Western Australia? Well, I and this gentleman think yes, it does. But it's a complicated story. It's not straightforward. Often we can't get women in utero to where we want them to be. No baby, by the way, has delivered in the back of an aircraft in nearly 40 years in Western Australia, and I think perhaps we have lost our ability to take the right types of risks. That's now an opinion rather than data. And I'd be interested to have some conversations about what we can do to stop this from happening, because I wish that my transport team was redundant. I wish we didn't have to have my transport team. Happy to be put out of a job, to have a quieter life, rather than run a transport service. But what could we do about it? As a perinatal community, I think that's where the question needs to be asked, and what we can do to collaborate together to try and find those answers in better centralisation of mothers who are at imminent preterm delivery. So my final thoughts, in a slightly Jerry Springer style, is that preterm birth outside a tertiary hospital has increased. That's a fact. Preterm babies born outside tertiary hospital are at risk of death and brain injury, more so than their cohort that are born inside a tertiary hospital. we need to explore creative solutions to try and work out how to better manage the presentation of the unexpected presentation of preterm birth. I know that the Preterm Birth Alliance has done great works in managing those we know that are at risk, but I think, as I hope to have shown you in our data, I think the people who are now at risk are the people who don't know that they're going to present in a place where they can't get tertiary care, they can't get active midwifery or obstetric management in the way they would have expected for their preterm baby, or the sort of paediatric care, stabilisation, up-to-date management that a preterm baby would and should get in order to optimise his outcome. There are lots of people we have to thank in NETS to keep the bus on the road, and all of these people have done so, and also, if you have a look at the Helping Little Hand stands at the back, Joanne B has a mocked up model of our actual ambulance that they have just very kindly bought us, that has arrived in WA. Maybe I'm up there, it is there, she's holding it up there. It's exactly like that one, absolutely 100%. All of these people do a great job in keeping NETS on the road, and to be honest, if you want to also make it up on a thank you slide, come and talk to me afterwards about how we can collaborate to make this whole process a little easier on our mothers, and also to find out about what other great research that we're doing in NETS. And I'll leave you with that light at the end of the RFDS tunnel. Thank you.